Hello, welcome along to the Prevention is the New Cure podcast. We're here discussing all things NHS and health related with a political twist. We, of course, being myself, Steve Brine, I represent Winchester in Hampshire. I'm a former health minister and chair of the Health and Social Care Select Committee in the House of Commons.
And I'm Helen Stokes-Lampard. I'm a frontline GP in the Midlands. I'm chair of the Academy of Medical Royal Colleges and chair of the National Academy for Social Prescribing.
Marvellous. So, Helen, we recorded the pilot last week. This is episode 1. I think it's Happy St David's Day to all you and our Welsh friends.
Diolch yn fawr I chi, Steve. And also I should probably say Dydd Gwl Dewi hapus I chi.
Well, you can say that, but I don't understand it. But we won't dwell on the rugby last weekend.
Oh, you wounded me. You wounded me.
At least they played and the strikes didn't kick in.
This is very true. And all I'm going to say is cricket and one run.
Yes, that's true. That's wounding. Anyway, well, look, we won't dwell. So we did a pilot last week of this little venture of ours, and I think feedback's been pretty good. I seem to have lots of places I've been, people seem to have listened to it and enjoyed it. I have to say though, Alan, the 70s doorbell that will come up later when we open the pod surgery has rather stuck, and people keep contacting me saying, well, I had that 70s doorbell as well, or I didn't know you were at Hazelmere Health Centre. I used to be a patient there as well. So Hazelmere Health Centre has achieved fame through the pod.
Do you know, Steve, I think that 70s doorbell was rife throughout 1970s and possibly 1980s health centres, because several people have said it to me. I'm sure my GP surgery had one of those as well. So we've created a whole nostalgia moment over the doorbell.
We seem to have, yeah. Well, anyway, we've had lots of very nice messages, so thank you to everybody who's
indeed. Steve, I'm recording this from London at the moment. I'm in the headquarters of the Royal College of GPs, but where in the world are you at the moment?
Well, just landed at Heathrow, actually, not that long ago. So been in the US with the Select Committee this week. Bit of a flying visit, to say the least. So on Sunday, we went out to Portland, Oregon, and then we went down to Silicon Valley in San Francisco. So yeah, we've been knocking up the air miles. I have to say, in Portland, last week they had 11 inches of snow. It's the most since the 1940s, and this weekend it's been snowing in Southern California. It was all very British, because they sort of fell apart, didn't know what to do with it. So it was quite reassuring.
That is quite reassuring. I mean, obviously frustrating, but very reassuring that we're not alone. But lots of talk about climate change.
Yes, I think so. I mean, I think they're just completely perplexed by it. I mean, on the west coast of the state, certainly down in northern, let alone Southern California, it doesn't snow. So when you're in Silicon Valley and you think you're going to see the California sunshine, and it's sort of mist and fog and there's snow lying around, yeah, it's a weird one. I mean, at Portland, I've always wanted to go to San Francisco. It's on the bucket list. But we literally flew in Sunday, and then we flew down on Monday night to California, and then we flew back Tuesday night into today, Wednesday, when we're recording this. So I think flying visit is I'm going to be in big trouble when I get home, Helen, because I was tasked with getting a can of Prime for my son, which is not very healthy at all. But my excuse is that I couldn't get liquids through security. So I've got some US candy instead.
Bad daddy. Bad dad.
I know, bad dad.
But look, so you were in some really interesting places. I'm guessing that it clearly wasn't a jolly on that schedule. So what were you doing and seeing there that we can talk about today?
So, yeah, well, I mean, look, that's we talked last week about strikes, didn't we? And literally later that night, there's been some movement on the strikes. So that was good.
It is, because the nurses should have been on strike today.
Exactly. So I think jaw is always better than war, right? So that was good. But no, the reason we were there, Helen, is because we are doing a big inquiry at the moment into assisted suicide. And I deliberately say it in that way because different sides of the debate call it those two different things. And Oregon was the first US state to legalize assisted dying, or death with dignity, as they call it. So 30 years ago, there was a man in a van called Jack Oversian, he was called, and he was sort of known as Dr. Death. And he used to travel around in the van helping people to die. He was eventually arrested, but that movement became, how in America, the citizens can get something on the ballot, and they then they vote on it, and they decided to legalize it. Oregon was the first state in the union to do it, and they've now had it for 30 odd years. And
Wow.
we were there looking at the detail of how that works.
And how did that? I mean, that must have been absolutely fascinating to go to where, in a sense, the center of the debate, where they've really gone through this in detail. Because, I mean, in my experience, this is one of the most contentious and divisive subjects that healthcare professionals talk about, but that society talks about.
Yeah, so I mean, like in my time in Parliament, we've debated it once in the House of Commons on a piece of legislation, which was a private member's bill by a Labour MP called Rob Maris, who represented somewhere in the West Midlands, I think, and it didn't get through. And it doesn't matter of public record, I voted against it. But no, it was interesting. I mean, Oregon was the first state, but by no means the last. There've been others that've done it. In Canada, they have something called the MAID provisions.
Yeah.
Medical assisted dying, it's called. They also have it in some European countries. So Holland's probably most famous. We're also probably going to look at. And yeah, I mean, look, it's highly controversial, of course. You have to go and see your doctor in person to request it. You then have to refer to another doctor and a second doctor. You have to have less than 6 months to live. You must administer the lethal drugs yourself. So even though you may be handed them by the physician, they can't administer it. And I think it's about 95% of people use the Death with Dignity Act at home. They have the family around them. Sometimes they have a kind of living wake beforehand, so you literally attend your own funeral. Wow. And so we heard from both sides of the debate how it's working, and obviously those that advocated for it and want it are pleased that it's in place. They say it's death with dignity. Those that are opposed are vehemently opposed, as is in this country. I mean, where do you think the debate is among medical professionals in the UK about this at the moment?
So this is a really topical issue. There's no doubt about it. And I think the decision by the Jersey government, I think it was last year, to move to implementing this for residents of Jersey. So as could be as soon as 2025, I think has reignited debate and discussion amongst healthcare professionals, because obviously Jersey is so close to us. This has been debated many times over the years by the various royal colleges. And so the current position, if I give you the three of the biggest organisations in their view. So the Royal College of Physicians, the one based in London, in 2019 balloted their members, and they changed their position from one of opposition to a change in the law to a position of neutrality, as in they would not oppose a change in the law. So that was really quite a big moment. And not long after, the British Medical Association, which is the doctors' trades union. So colleges are all about standards and the highest possible quality of care for our patients and ensuring doctors are at the highest standard, whereas the British Medical Association is the doctors' trades union. But the BMA have a strong ethics committee, and they did a similar exercise of their members, and they too moved from a position of opposition to a position of neutrality. But the Royal College of GPs, and clearly general practitioners, have the greatest amount of frontline contact with the patients and the public. They're based in the communities, they have the long-term relationship with public. They conducted a similar exercise amongst GPs, and they retained their position of opposition to a change in the law. So you've got a split in the medical profession. And I think, and actually, when you look at the details of the votes, they were miles and miles apart, but the conclusions were different. And I think that tells us a lot. And certainly over time, doctors have become less opposed on balance. But there is a very wide range of views. And ultimately, whilst doctors have to be actively involved, some doctors would have to be actively involved in any process, this is a decision for society and government and politics, not a decision for doctors. As long as, if you go for that route, you have sufficient numbers of doctors who are prepared to participate. And all indications are that if the law changed, there would be sufficient numbers of doctors. But I mean, it tears you apart.
I think that's a key point, is that in Oregon, they were doctors are not forced to take part in the death and dignity legislation, but of course there are plenty that do. One thing I found really interesting is that if you have lung cancer and obviously the physician says you have less than 6 months to live, and you seek death with dignity, the death certificate says you died of lung cancer. So there's no distinction made there, because this is not assisted suicide. So therefore, your life insurance does not become invalid, for instance.
That is
so
interesting.
the death certificate says what your physical state was that led you to that. Now, the cost of this, of course, because in the States, and this would be a big issue if we were to go down this road here, the cost is largely borne by insurers. So I think about 90% of people in Oregon who use it have insurance, and so in a way, it's not for all. It's not for all in Oregon, because if you can't afford it, then it's not an option to you, is it? So that, I think, that is, if it were to become legal here, then of course, the question would come, well, would the NHS bear that cost? Because the drugs, although they've come down in price in Oregon, it's still not an insignificant cost. Would that then become an NHS cost?
I mean, I'd never thought of that particular issue, partly because I think we're so used to the NHS covering everything when it comes to anything around care, and certainly end of life. And, palliative care costs are mostly covered by the NHS, although we do have a huge number of brilliant charities working in this space, supplementing the work of the NHS. Some bits they do with contract in the NHS, an awful lot is fundraising money. But that does raise a whole heap of interesting extra questions and arguments and debates. For me, what I think is interesting is the difference between what healthcare professionals want for themselves or their loved ones were they to be faced with a decision, versus what they want their profession to be doing. And I think it's an important distinction, because what we feel, as healthcare professionals, most people argue and understand our role is to ensure the best quality of care for patients and the best possible death when it arrives. And ideally, what we want is brilliant quality palliative care available, so that people at the end of life can die with dignity, pain-free, symptoms minimized, in a way that is of the patient's choosing. So if they want to die at home, they're supported to do that, in a hospital, in a hospice, whatever. What's interesting is a lot of healthcare professionals I talk to say, but actually for myself, I want that element of control. I'd like to be able to choose the moment. And I'm afraid that the palliative care system is under such strain that it won't be there for me. And I think we all know of the bad death. One of my mantras as a GP is that when we help people at the end of life, when we get it right, the families never forget. But when we get it wrong, the families never forgive us. And that's the sort of thing you carry with you as a healthcare professional.
And, I just sort of finally on this, I think it's a very sensitive subject to discuss generally, but this particular point is that, the people that we met and that I've met here who are very passionate about changing the law, they have experienced and witnessed very bad palliative care ending very badly. And so you can understand why they have that view. I've seen both my parents pass, and they weren't, it wasn't a bad death if there's such a thing, you know what I mean? So, I don't have that trauma from that, but I fully appreciate the situation that people are in where there is that. So anyway, the select committee are looking at it. We're doing our field work. The slippery slope arguments. In Holland now, you can seek assisted death for mental health problems. In Canada, they're considering, and they will very soon extend their medical assisted dying legislation to include mental health problems. I have major issues with that. We did a survey on the select committee when we sort of launched the inquiry. We've had just short of 70,000 responses. Whoa. So you can see the interest in this. So we're not going to come to a recommendation that government should change the law or leave the law, because ultimately this isn't a government decision. It will be a parliament decision, because it's a backbench free vote. It'll be a backbench free vote issue. And we're going to look at palliative care. We're going to look at examples around the world, and then we're going to write a report, which I suspect will inform the next parliament. Anyway, let's take a quick break, and then we'll come back and talk about some of the other things we were up to the other side of the pond. So the other part of what we're in the States, we're doing this big piece of work at the moment on digitalization of the NHS and how that can help patient care, how that can help with our workload challenge, how that can help with our demand. And we're also doing this massive piece of work, which is obviously the name of this podcast, prevention. Good. And so we were in with Google, and we were in with Apple. We went to Stanford Hospital and looked at how AI is helping read scans and their medical imaging, which is just a phenomenal world. So, Google Health, which is a massive part of what they do as a business is really interesting. You'll see the Apple Health app on your iPhone, which sort of was originally sort of a step monitor, I suppose. It's now a much, much more comprehensive app that looks at all sort of elements of health and sleep. So, we were talking with some of the big tech companies about how they can insert themselves into the health space, and they really want to. And interestingly, Tim Cook, who's the boss of Apple, said that when he looks back at the history of Apple, he wants it to be about healthcare and how they helped keep people healthy.
Gosh.
Which is really interesting, isn't it?
So, as opposed to making lots of money.
I think they'll do that at the same time.
Okay, just check. And just to clarify, other, to Android listeners, other platforms are available and other apps are available too.
Yeah, hence Google. But I know it was remarkable to listen to the work that they're doing. And as I say, Google Health, there's a lot of synergy between the work that we're doing on the prevention inquiry, looking at all this different thing around activity and exercise, and the physical health, mental health, sleep, housing, the environment. There's such amount of synergy there, and we are convinced that digital has a role to play in that, and also a role to play in the NHS. So the way that AI is able to, Stanford, the way that AI is looking at medical imaging, for instance, and working alongside our radiographers is incredible. I mean, that would be something presumably the medical profession you would welcome.
Oh, absolutely. So, I mean, you've thrown in so many things there for me to pick up on. So let's start at the end.
Sorry.
No, but the AI and medical imaging. So, it's fantastic. So, my radiography colleagues, and in fact, through the whole of the diagnostic specialities, so pathology as well, there's a massive role for AI. So, anything where there is massive amounts of data which has to be interpreted, where over time learning and exposure to more and more images makes you do it better, is logically open to AI in terms of a supportive tool to help the clinical picture. What's fascinating, however, is the complexity of human beings and all the nuance and all the subtleties of things that go in. Is the AI is amazing at the hard stuff, the data processing, but it works best when you put an experienced human alongside it to put the context. And I think whereas perhaps 5-10 years ago there was anxiety, people thought, is this sort of thing intended, people thinking this is going to take over our jobs, and what we're hearing now very clearly is absolutely not. This is about brilliant clinicians being supported by the best possible technology, and that is the winning combination. For me, for the NHS, I think there's an issue of our baseline technology and yet our brilliance at the front end. So I see these amazing whizzy examples of quite astounding technology and how it can support our ability to deliver care, the real cutting edge. But we are hampered on the front line by some really rocky technology, the lack of interconnectedness between primary care and secondary care, the challenges my colleagues in secondary care have about prescribing. In my search, I've been in surgery a couple of days this week, and it's been really heavy couple of days. And when I thought about the tech that's made my life easier, some has made it easier, some has made it harder, but the stuff that's made it easier, electronic prescribing. Patient phones up, quite literally, doctor, my daughter dropped her inhaler down the toilet. She's breathless. No problem. Where are you? We're on holiday in Center Parcs. It's okay. Give me the postcode. Right. I've just sent a prescription to a pharmacy, which is apparently 2.5 miles away from you. Go and pick it up. I've told them you're on your way. Those kind of things are brilliant, but my colleagues in secondary care haven't got that luxury or that option. All they can do, and in fact, I received the most awful handwritten scribble from one colleague. I won't name the speciality, but it took 4 doctors and 2 receptionists to try and decipher what on earth was written, to then turn it into a prescription for the patient. This stuff we can do so much better.
Yeah,
and I know that's really basic end, but sorry.
I mean, I'm convinced that that tech is a key part of it's not the only part clearly, but I think it can be a key part of scaling the workforce challenge. I think it can really help. We can't just exponentially just keep increasing the workforce, even if we can click our fingers and fill all the gaps. So I think tech can really help with that.
Tech empowered.
Now, you wanted to talk about cancer.
I do want to talk about cancer because it's such a massive topic that affects so many people's daily lives. But I think we should just touch on the fact that today the Public Account Committee released the latest report, and it's titled sort of Managing NHS Waiting Lists and Backlogs. But the focus of it's been about cancer waits. Now, I haven't had a chance to read it all in detail, but I know that some people are unhappy with what it says because, I mean, the Public Accounts Committee do brilliant work, and you can tell us more about that. But
they do.
essentially what the report is saying is that could do better, that the system is not responding fast enough and well enough. And I think a lot of people who are at the front line, both in commissioning the services and busting a boiler to try and reduce the backlog, are feeling a bit bruised by it. What do you think?
Well, the first session we had since I took over the select committee, we had Carrie Palmer, who was the National Cancer Director, in with Professor Peter Johnson talking about cancer recovery, basically. So getting back to pre-pandemic levels, the 62-day wait, the 28-day faster diagnosis standard, all this stuff that, as we know, really matters when it comes to cancer and early diagnosis. So we can talk about, and we will as on the select committee, about all the whizzy stuff and vials of blood that can give you early stage detection of some very hard to detect cancers and the stuff we talked about last time. But the basics of getting people, with the number of cancer presentations being as high as they are, getting them turned around and then treatment in a timely manner where that's required, which in most cancer cases it is. We're off track. And Meg Hillier, who chairs the Public Accounts Committee, sort of cuts across all of our different committees, all the different work we do. She's brilliant, and she's got a very forensic select committee there that work with her. And we're actually this month, because we're in March now, aren't we? This month we've got Callie and Peter coming back in to assess where they are on the 1st of March, because they said that they would have a key staging post at the start of March as to whether we were recovering our cancer waiting times. And from what you haven't seen the report, from what you're saying, it sounds like that they've got work to do.
Yeah, and I think what's a bit sort of difficult is the report the report states they've got quite a lot of work to do, and yet the figures that I'm seeing is that more people than ever before are being checked. I think we're up to something like 114% of pre-pandemic levels on urgent cancer referrals. More people than ever have come forward for their cancer checks, and more people than ever are starting cancer treatment. So, and the waiting list, the people who've been waiting a long time for treatment have come down, certainly at the long waiting end. So I think there's a lot of really good progress. And I guess what I would really not want people to be too taken up by some of the very negative headlines that have been in the media today. And actually, there is a lot of really good news out there about what's being done. And most importantly, if you've got a worrying symptom, please come forward for it, because what we can't do in healthcare is we haven't yet discovered NHS telepathy. We're not telepathic. We don't know you're unwell at home. Come forward. Then we can start.
I thought you could read people's minds, Helen.
Well, I have a personal superpower.
Yeah, clearly you do. Listen, on the subject of superpowers, you know what it is time for, don't you?
Oh, no.
It's time for the pod surgery. Okay, surgery sign up and open. The doorbell has donged, if that's what a doorbell does. Who have we got? Who's been in touch, Helen?
So we've had loads of people being in touch, but I think there were two people. I think Claire Kavanagh and Sam Felton got in touch about diabetes. Sam actually got in touch about a much wider public health collaboration based in your constituency in Winchester.
Yeah, he is.
Yeah, really, really interesting stuff. But I guess diabetes, type 2 diabetes, sorry, not type 1 diabetes, but type 2 diabetes is largely preventable. And there are some amazing initiatives out there. So for people who have been diagnosed, if you aggressively go for helping them with their lifestyle management, you can halt and even reverse type 2 diabetes. And there's loads of research in this area. There are brilliant examples. There's a Dr. Unwin in Southport, who's a GP who I've met, who I've got huge regard for, who's done some amazing work. And Sam brought to our attention the Lifestyle Club, which has been rolled out in a pile of PCNs, which are doing great stuff in helping people turn this around. And it's what we call a teachable moment. You get a major diagnosis, it's a teachable moment. We can do stuff and change your life this way. What about you?
Yeah, I mean, look, diabetes costs the NHS in England, £10 billion a year. So, goodness, if ever there was a subject where prevention is applicable and needed, it's that. But I mean, you as GP, Helen, presumably you refer people onto the diabetes prevention program all the time, and with varying degrees of success.
Yeah, it's really interesting. People respond incredibly positively to it. So, I mean, the diabetes prevention program that we've got is great, but there's always a lag and there's a waiting time to get into it. And we just need a lot more capacity in it. And what is interesting to me is we've got some patients with fantastic response to it. But even those who don't have much response to it or don't engage with it are very grateful for the opportunity.
Yeah.
So I think this is the sort of thing about people appreciate the opportunity to take control themselves. I think there's a lot of issues about different parts of the country, people from different groups, backgrounds, and their ability to engage with it and how relevant they feel it is for them. So we need to be ethnically and culturally sensitive in programs we're offering people. This stuff takes time. But what we shouldn't be doing is, doctors, specialists shouldn't be spending their time focusing on this. This should be for people who are trained specifically and have the time to spend to help motivate and encourage the public who are given a diagnosis to take more control. And I then,
well said.
Yeah, for me, can we talk a bit about starting young and childhood obesity as well? Because I'm quite passionate about us helping our young people to set them up for a healthier life, a life that's, with prevention built in from the outset. I know you've got views on that.
Yeah, of course. Yeah. And that's what Sam's talking about.
Yeah, I think that's right. Sam and this lifestyle club certainly talk about it in sort of adults, but there's also the childhood obesity. Have you come across Veg Power and Dan Parker, which is about getting more children?
I have.
They're great.
Yes, he's contacted us, and he wants us to talk more about this. And I think this is a whole subject for a pod on its own. But I mean, I remember when I was a health minister, we wrote the child obesity plan, and it contained stuff about reformulation of sugary drinks and advertising restriction changes, which still haven't come in. But
indeed.
we've got to recognise, haven't we, that children who suffer with obesity obviously grow older and become heavy adults, and then they're at a risk from type 2 diabetes and all cancer and all the other problems that we know exist. I've got one here from, I think it's Dr. Gray. Steve and Helen, I agree, prevention is better than cure. But try telling that to the multitudes that can't access an NHS dentist and can't afford to go private. So we had a letter last week from our NHS dentist, me and the kids and my wife, saying that after much thought, and I think it has been agonized thought for many doctors that leave NHS dentistry, that they're going purely private work. So this is about the contract. The contract basically pays doctors for UDAs, units of dental activity, and they feel that it means that they don't get quality time with their patients, and that really what they're doing is filling teeth, and they're not looking at oral health and prevention of poor oral health and all the other things that dentists can pick up. I mean, I've heard examples of dentists picking up brain tumors because they're right up close, picking up oral cancers, and so there are too many NHS dentists leaving the profession. And what I'm picking up is even if the contract changed tomorrow and it was much more based on prevention, it wasn't just based on the units of dental activities. The trouble is, so many dentists have left the NHS that who's going to provide this work? And in wealthier areas there are people can maybe afford to pay more or pay to a dental plan, but in many areas of the country where we've got dental deserts or where we don't have any NHS dentistry, I really worry that people will just say it's a luxury they can't afford.
And I'm so glad this topic has come up, because as a general practitioner, I know that my life gets so much harder when my general dental colleagues aren't there doing their bit of the prevention piece. So we have a terrible problem with children and young people's oral health. And the single biggest reason for children to have an operation is to have dental extractions. We are having children having all their baby teeth extracted because they are so rotten and in such a terrible state. And there's a range of things. This is not just about our dental practitioner colleagues, this lack of access to them, but it's also about health visiting services and education of parents about oral health for their children. But this is actually a really urgent health crisis now, and we are setting ourselves up terrible problems for the future. If people don't have good oral health, it impacts directly on cardiovascular health later in life, increased risk of a whole heap of cancers. So I mean, we really need our dentists to be supported better. Yes, it's a new contract. Yes, it's initiatives into training more dentists. And how on earth, I mean, the most cost-effective thing to do is to attract people back from private practice into general NHS dentistry. And that's going to take a big investment and a lot of political will.
I think it's going to be hard, though, because the wisdom is, they leave and go and work in private practice where they earn more money. Not necessarily so, actually. Quite often not the case. But they've taken a very difficult decision to stop doing NHS dentistry. And that's been quite hard for them. And I think then the idea of going back I think they're just. I think a lot of NHS dentists who've moved across are just like,
Yeah.
enough already. This
Yeah,
is
burnt out.
exhausting. And in the words of Taylor Swift, so they're where they are, and I take some responsibility for this because I was dental minister, and there've been successive dental ministers in successive governments, Labour, Coalition, and Conservative, who haven't gripped this, and we are reaping what we've not sown.
Yeah.
And I worry, Helen. I worry about this one. But anyway, so Dr. Gray's raised that. He's quite right to do so. I think we might have to wrap it there.
I think
But
we might.
there's so many things that people have been in touch with us about that they want to cover in future episodes, and we've also had some quite interesting offers of some quite interesting guests,
Haven't we just?
we will leave that as we'll leave that as a tease. But there will be some interesting guests joining us over the weeks ahead, where maybe we talk about one subject in particular on the pod instead of jumping around as much as we have. But yeah, it's been great to see you, Helen. Great to talk. I don't feel too jet lagged, but anyway, listeners' input is always what we want to hear, isn't it? We want to hear from what they think about the pod, where they enjoy it, and the feedback, of course, on what they want to see us talk about in future.
Absolutely. Steve, keep yourself well hydrated and get to bed when you can. But yeah, all sorts of suggestions gratefully received, political and medical health, but also wider health and well-being. Obviously, prevention's our focus, but as you've heard, we're happy to touch on anything that is health and care related.
Now, you need to go and get your glad rags on, because presumably you're off out partying tonight, are you? Since it's
Absolutely. Painting the town red and blue.
And yellow.
Of course, and green.
Lots of love. Till next time.
Take care. Bye-bye.
Goodbye. Bye.